We are the Committee of Office of Finance and Budget. I should get the whole long title. But anyway, more importantly is that it's the Office of Finance and Budget. Is conducting a series of budget hearings. And for this morning, we have the Guam Memorial Hospital Authority. And I'd like to let everyone know that Senator Pangilinan apologizes for not being at today's hearings. But the OFB staff, will continue, of course, to provide analysis for the committee to transcribe and to also transcribe these hearings. The Senate, I announced a couple of days ago that he was in Washington, D.C. to deliver an address or a speech in Washington, D.C. And this morning, he did deliver it regarding the military housing privatization initiative. And if anyone, of course, has any questions or concerns regarding the budget hearings, please submit them to the Legislature or contact the OFB office at 473-4236 or 7. So I'd like to thank my colleagues who have joined me this morning for this public hearing, and the chairman, of course, of who has oversight of Guam Memorial Hospital is of Health, of course, is Senator Dennis Rodriguez. I'd like to also thank my other colleagues who have joined me, Senator Yamashita and Senator Silva Tyhern. So Mr. Vega, I understand that you're here with others as well, and if you can please take some time to introduce who's here with you this morning, and then you may proceed with your testimony on your budget.
Thank you, Madam Speaker, Senator Judy Wonpat, Senator Aileen Yamashita, and Senator Mana Tyron. My chairman of my health, Senator Dennis Rodriguez, good morning. And thank you for the invitation. And as I was talking to the staff, I think it's been a while that the GMHs personally appeared and presented their budget to the legislature. And I take this as an opportunity for us to talk about the budget, and should there be any matters that you need some clarification, that would give us an opportunity to give you one. Joining me today is Dr. Larry Rizama. He is the medical director, and to my left, June Infante, acting CFO. Good morning, everyone. Shall I go on, Senator? Thank you. We are here today to present the 2013 budget for Guam Memorial Hospital. As the numbers would show, we have significantly reduced the budget numbers for this year from 112 for fiscal year 2012 down to 93 million. As we progress through the discussion, we will be able to provide you the difference and where is that coming from. But in general, most of those, about 16 million of the 18 million difference is coming from the salaries and benefit. The rest would come from supplies and contractual obligations. And in particular, I would like to turn this discussion to Mr. June Infante for the specifics of the budget.
Good morning, Senators. Okay, I did an analysis of the budget. The budget is $93.4 million for fiscal year 2013. We are scheduled to get 13 million from GovGuam as the pharmaceutical fund, gross receipts tax, and Healthy Futures Fund. That will total to about 13 million. So 93 less 13, we are anticipating to collect 80 million in receivables collections, patient collections. This budget does not fund vacant positions. And that is about, when we earlier did a budget, it ballooned to 104 million, and that included 6 million, the value of the vacant positions at the time. December staffing pattern was $6 million. So I'll say that we removed $6 million and other things, so it became $93 million submission. Now there, if you want to talk about the 2012 budget, we are tracking to spend from 97 to $98 million this year. Okay, so we submitted a $112 million budget, and we're tracking to spend 98. So we are expecting to spend less, and I believe that is due to the not paying the increment for this year. We have stopped, actually reduced the hiring because of the freeze, and we have cut down on a lot of expenses. We have not funded any travel except for federal travel, funded by the federal grants, and we have just maintained operations. Those are the highlights of the budget. If you have questions, we'll answer.
Well, actually, we were we would like to hear, from, of course, your the defense, of course, or explanation of your request. And from the analysis, of course, we realized that there is almost identical number from GMH's request and the governor's ceiling for the hospital, which of course is a lot less from what you were currently for this fiscal year been appropriated. And so and we do have some questions, and maybe that might explain it more if we move forward then with the questioning, and we'll do some comparison. In the analysis, of course, that was done is that the hospital had submitted a $93.4 million budget request to OFB, which is a 17% decrease, okay, compared to the current fiscal year appropriation levels. So the GMH budget request then is consistent with the 2013 executive request ceiling, because remember, and the hospital request was 13.020. That's the hospital's request. The governor is 13.021, and that is a decrease of about 3% of your appropriations for this year, which was $13.4 million. So that's, we calculated then that there's a 3% reduction there, and these are monies that have been appropriated from the general fund, from pharmaceutical fund, and the healthy futures fund. Those are the ones that made up the 13.4 that you're currently had been appropriated. The fiscal year 2011 actual expenditures is $98 million, and the Office of Finance had received from you as of May 2012 the actual expenses incurred. So with that document then, of course, OFB was able to project then that for your 2012 expenditures, which amounted to $88.6 million, compared to your budget submission of the $93.4 million. So the questions, of course, that I'd like to ask, because in the breakdown, is that the largest decrease, well, the total decrease was $10 million from the current year projected expenditures of 88.6. And the object category for 2012, where you have the largest decrease, is $2 million, and because your actual expenditures for 2011 was 8.3 million, your projected, as you can submit the documents to OFB, and May was the latest, you've submitted already that your expenditures are $6.4 million. And so there's that 2 million decrease. And so the question then is, why that significant decrease? And can you explain to us then, as of today at least, it's...
The decrease in 2012
yes.
expenditures?
By 2 million.
Actually, that we are not paying increments. That's,
No, but
that's a big item.
But the object category where we're seeing the difference is on contractual services.
I saw that one too. There's a $3.2 million decrease between last year and this year, and if it's just budget to budget, there was a misclassification of budgetary expense, like for American Red Cross and actually the laboratory reagents. I'm not sure why they put that in the 2012 budgeted as contractual when it should have been supplies. In 2013, we put that in supplies. And also, there was a mistake in the budget for a skilled nursing facility. There was an error. Somebody put a budget for $900,000 for repairs of radiology equipment. So what I can say is that the 2012 budget was poorly prepared. It's a $112 million budget, and we're tracking to spend 89 million.
You're right, and that's the dollar amount that the office was able to decipher from what you've been submitting to OFB. And you're right, your projected expenditure would be $88.6 million. But then again, compare to your actual expenditures for 2011, it was $98 million. So I mean,
we expect to spend less this year because really the personnel expenses, and we're cutting down on travel. Travel is not a big item.
I understand
Yes,
that, and we can appreciate that. But where the numbers are showing, they're showing on contractual services a $2 million decrease. The other object category where we're seeing again a decrease, this is a large one, is a decrease by $5.4 million for supplies and materials. And the third decrease is on equipment, and it's not as large, but it's a decrease of $171,956. But so that then totals almost $10 million, and we never expect to see this from the hospital, considering, of course, that you do have some financial problems. So I'm wondering, and I have to ask the question: are you spending less in these areas because maybe of the non-availability of cash? Are you getting your allotments or not? I mean, what is happening here?
We are getting our allotments from DOA. We are receiving that. We have just really consciously cut down on expenses, and it's a pleasant surprise to us too that we're keeping it down. And I believe really the 2012 budget was erroneously prepared. For 2011, we submitted, I believe, a $99 million budget, and I really could not understand why we submitted 112 at the time. It will take post-mortem to analyze that, but really for whatever it is, we will spend, I believe, 88 to 89 million this year, and we're tracking to collect that much money from our own, our collection. Our collection for this year, as of May, is $56 million. And if we collect $7 million for the next 4 months, our collection for this year is $84 million on patient collection. So if we collect 84 and in 2013 we're saying we want to collect 80, that means even in 2013 with more effort we should be collecting more than 84. So it's just numbers right now.
So, so to get a better understanding of this, then, is that if you are, because this is not anticipated, of course, and as part of, your budget, that when you get this collections, when they do come in, then that will be more like, in addition to what you're currently receiving. And could that be? I mean, we're just trying to find
Yes.
some explanation here, and I'm hoping that maybe if there are some errors in the object categories in which expenditures were drawn down, that you'll be able then to explain that, because like we say, is that when specifically when we think of contractual services, what contracts do you have, or maybe you don't have, and that's why there is that less the decrease of $2 million. But then there's the supplies and materials. This one is really shocking, is the $5.4 million less, or a decrease. And so unless your patient numbers have changed lower, or maybe the treatment of those particular patients that do not need maybe certain supplies and materials, that has warranted a reduction in your expenses for supplies and materials. I mean, that's what we're trying to have, better handle of.
I will admit that the patient numbers are down. Our billing is less than last year. If you compare the billing, I think we're billing 7 million less May to May, and these are posted in the website. We post all these numbers in the website, and I noticed the billing is less. A census is less, and couldn't put my finger on that one. Maybe some other people can answer, but I know that the billing is less, and we're trying to find out why. It could be that we're short of personnel in the business office, trying to get a handle on that too. And to go back to contractual, we are not, for last year we budgeted for travel nurses. We don't have travel nurses anymore. We have travel dietitians right now. We're still short of dietitians. The transcription expense has been less. We used to pay 18 cents a line for transcription. Now it's down to 11. We're saving about $160,000 on that one a year. There are savings that we're trying to look at, not as fast as we can, but I don't know what else to say.
No.
We will look at the numbers some more.
Yes, can you, we would definitely like to leave this open to get more information then from you in terms of some of these decreases, like you said, no traveling nurses, but more traveling dietitians, and what are the comparisons and the numbers for that, the less patients. Again, data is really very important. See, we didn't even know that. We're always thinking that the patient numbers have increased because if, when you look at the newspaper, you see that red
Red is
block,
there.
if that you mean you're at and beyond capacity. We're seeing more of that, and maybe it's because of that we're thinking that that there'll be more to expend rather than less. So to continue on, for fiscal year 2012 appropriations, now I'd like to do a comparison with 2012. So your request is $93.4 million for this coming fiscal year, which is a 17% then decrease from your current 2012, and your authorized level is $112.2 million. In doing an analysis of all the different divisions, it showed that there's a decrease in in your request, and of course it's nominal, like 1%, and some has a nominal. Administrative division's the only one with a nominal 1% increase. And your funding sources, of course, for all of these are, again, patient revenues, grants, pharmaceutical fund, general fund, and healthy futures fund. So, and maybe you can explain this, because the only one, of course, that we saw an increase of 1% is administrative division from 2.505 to 2.519. There's a $14,690 increase, and that's for administrative division. Can you explain what that increase is then?
It's just $14,000.
Yes. Is that one
we,
person?
We
That
actually, in detail, we increased the legal expense budget.
So, okay, so you're saying legal expense.
Yeah, it's about
Okay, so that-
200,000 we increased the
Okay.
budget.
All right, so that's where that is. For operations, there is a decrease by $2.8 million. For fiscal services, a decrease by $671,924. For medical division, there's a decrease of $914,815. Nursing services division, there's that's a larger one, a decrease of $9.8 million. That's a 24% decrease for nursing services. And that, if anything else. And the next one, professional support division, a decrease by $4.5 million. So maybe those two, if you can try to explain to us, because of, our university is working really hard at recruiting for nurses. My understanding, because I have a former student is going in the nursing program, is not going to be able to do anything for this year because already the 2012 class is going to move forward in their nursing program, the class is full. So now this individual has to wait till 2013. So we're pumping and trying to support the hospital and our patient care and health services on the island. But we're seeing now a drop in terms of nurses services division, and I'd like to know what that is, of the drop of $9.8 million.
Thank you, Senator. In the beginning of the fiscal year 2012, the total 293 vacant positions were identified and reevaluated. Out of the 293, through the Board of Trustees and Management, we identified 164 positions that we believe historically, based on the length of time that they've been left vacant, though funded, we believe that we can do without that in the meantime. So that's 164 positions.
164
Positions.
vacant positions, but these are budgeted positions.
Right. Yes.
So could we then? So then, if there are budgeted positions, and you chose not to fill those positions, then those dollar amounts, if you add them up, what then would that come up to?
The 164 total would amount to about 4.36 million.
Okay, so that's a partial explanation then for why the decrease,
Right.
because you didn't fill
Right.
your vacant position.
As we evaluate the vacancies, we have restricted the recruitment as much as possible, so as not to impact on patient care, delivery of patient care and services. We are not hiring even on the clinical side. We're not hiring new nurses. We are only replacing as they retire, resign. So the rest of the 129 positions that were identified related to the nursing services and the clinical services, they have not been filled really. Most of our recruitment right now are just for the replacement of those who are retiring and resigning. So this is the difference. We're seeing a difference too on what the remaining 129 positions that for the fiscal year 2012 we did not, as much as possible, fill. So some of the difference on that 9.8 are probably on the vacant positions.
So the biggest question, I think, in the minds of everyone now is that with this significant decrease, do you have somehow the confidence in the hospital's ability to provide then health care services to our community and also to maintain your accreditation?
Yes, yes, ma'am. We are on a day-to-day basis. We have the nursing director, acting nursing director here to respond to any specific questions. But yes, on the day-to-day basis, we're evaluating our staffing pattern. I guess if I can share this with you, as we are not replacing, as we are not recruiting for new employees, we practically depend on scheduling, creative scheduling, and on a need-be basis, we allow them to do work overtime.
Okay. Oh, yeah, because I want to finish all this in the budget because.
You know, we were tracking the staffing pattern at the beginning of the year. We started with 110350, and we're tracking the vacancies. And in November, the vacancies is 114.68 out of the 1,100. As of April 30, it's 126.67 vacancies. As of May 31st, the vacancy is 126.33. So the vacancies are constant now, and the vacancies we can identify is 17 in housekeeping, vacant positions, 10 in facilities, vacant positions, 4 in admin, in administration itself, there's 4 vacancies. In fiscal, there are 6 vacancies only because the positions, as Mr. Vega said, the vacant positions that we removed, part of 164, some of those are from fiscal services. Now, in the nursing area, there's 45 vacancies. And these are up for replacement because I don't think we put a hold in hiring patient area employees. There's no, also in laboratory, pharmacy, the ancillary department, there's 31 vacancies. So that will add up to 126. I can give, I sent a copy of this staffing pattern to Ari from Senator Pangilinan's office, so she has these numbers too. So we are tracking the vacancies, and it's been constant. So Mr. Vega is correct. We're only replacing the ones that are retiring or resigning patient care employees. The other areas we are not hiring.
So can you submit then the list of the vacancies where you've decided that you're just not going to hire? Because and it's a comfort at least to know that you are going to replace, of course, a few of those 45 vacancies for nurses, and then the other, the laboratory and technician positions, 31 of those that you're going to continue to do those. But it will also be good to know what positions you've decided to either freeze and not then hire. But it just kind of concerns, I think, all of us, because all of us sat in that meeting at the hospital that Senator Rodriguez conducted, and one of your nurses actually spoke and spoke of the criticalness of and how everyone is tied to each other, that they all must do their jobs, from the person who does the cleaning all the way up to services actually then provided by nurses and doctors, that they just go hand in hand in providing health care. So, but I think it'll be important for us to have that information. Now we have a chart that I'd like to discuss with you, and just to give again the listening audience an idea of where and how we appropriate monies to your department, to the hospital. And there, like I said earlier, there's a 3% decrease in fiscal year 2013 requests for the general fund, pharmaceutical fund, and healthy futures fund from GMH compared to what the current levels is at 2012. The pharmaceutical fund consists now 4% of all business privilege taxes are collected in Guam that will be deposited to GMH. So that's 4%, whatever that dollar amount is. The Healthy Futures Fund consists, of course, of a fixed amount of $1 million of tax collected, and then that's appropriated to GMH. So, the legislature has really been trying to make sure that, we earmark certain amount of monies strictly for the hospital to make sure that you're being funded. And then for 2012, GMH also, received appropriations. The difference will be from the general fund. And like I said, that amount was $13.4 million versus what then you have requested, which is $13.02 million. And then the governor's ceiling is 13.021. So actually, you guys are just, almost the same, with the exception of maybe a couple of thousands of dollars. The general fund, to give you an idea of your funding, is that in 2012, you've received 15% from the general fund for fiscal year 2012, 64% from pharmaceutical, 20% from Healthy Futures Fund. And your request and the governor's request are identical. So for the general fund, the governor's requesting that your ceiling would be 19% from the general fund, 70% from pharmaceutical fund, so there's an increase there, and a drop in the Healthy Futures Fund from 20% to 11%. And that's the governor's, ceiling for the hospital. Now for your new request then now for 2013 compared to 2012 is that for contractual services, again, we're seeing a trend that there is a decrease of $3.3 million. Can you explain then what contractual services will you be cutting for 2013?
There will be a reduction. We have reduced the cost of transcription. This is an outsourced service. There's a misclassification again, I said, in the laboratory expense. There'll be no more travel nurses. There'll be travel dietitians. And the visa processing, it's only like $68,000 in HR. We reduced that budget. And there's that repairs. This is an error. Most of these are errors. The reduction in contractual between 2012 and 2013 budget, there's a $948,000 error in budgeting. Sorry.
That doesn't sound good, coming here and telling us that you're making, all these errors somehow. It really doesn't. And I think you guys need to clean that up. I'm sorry. Because for one thing is that we take this very seriously when your requests come in here, and then we go through the breakdown of all the different object class, categories. You're going to need to know exactly what falls under contractual services, what falls under, supplies and materials, what dollar amount will be considered that, what dollar amount will be considered, equipment. All those you need to be able to get right so that we don't have this problem and this confusion. And even worse is that if critical monies need to go for certain supplies and materials or for services, and you've depleted the monies there because you've erroneously used it for something else, it's unconscionable.
We agree, Senator, and that doesn't happen. No department in the hospital has been denied supplies. They can attest to that. That is not an issue. We have issues with vendors because we have a big accounts payable. We try and manage that. On a daily basis, we take care of vendors putting us on hold. The cost is not there every day. We have a challenge every payday. So those are existing challenges. Now, if we go back to the funding that we get, the GRT is not actually a subsidy. 6 million of that is being used to pay for public health services, Medicaid services. So it's not a direct subsidy. And 3-4 years ago, we used to get $11 million direct subsidy from the government, but somehow that the payment mechanism has changed. We use that to pay for public health program in the Medicaid. So we are asking this committee to see to reverse that. I'm not sure it can be done, but we are asking. We used to get straight appropriation and payment from public health for the services that we do, but now we have been limited to the funding source, and I think Mr. Vega can say more about that.
Yeah, thank you. What Mr. Infante is saying, that the original intent of the pharmaceutical fund was to assist the Guam Memorial Hospital as far as operational activities. Initially, the fund was given to GMHs as to use for operations. Over time, and changes with the public law and the pharmaceutical fund, aside from the decrease from the original 6% to 4%, as the public law that covers the pharmaceutical fund for this fiscal year 2012, they allocated about 8.01 million. 75% of that will be applicable to Medicaid eligible charges. So actually that 6 million is already a revenue for us, but given that that's the way the law was created, only 25% of the 8.01 million can be used for operational funds. So to us, that's already money that's supposed to come to us, but we're paying for our own services. There's a lot of discussion as far as how it happened, why was it done. There are some discussions as far as the way it was done is that it could be used as a local match, which is a creative way of doing it. But at the end of the day, we are still short the hospital because we're paying for our own services, as what the legislature is saying, that we have appropriated pharmaceutical fund for you. But at the end of the day, I said, the Senator, I hate to repeat myself, but we're paying for our own services because 75% of the pharmaceutical fund applies to Medicaid eligible charges, services that were rendered to Medicaid clients at GMH. So what June is saying is it would be nice if we could use that pharmaceutical fund really for operational activities.
Well, I realize that is a policy issue, but then at the same time, I think it's important to understand that when certain funds are created and they are, placed and deposits are separate from the general fund, is that we just want to make sure that however we created those funds for, by definition, of course, is that they actually go back to, the areas, of course, in which many times what they're collected for. One of the biggest question or concern that, members would have is that if we create a pharmaceutical fund, but yet it goes to operations versus maybe using general fund for operations and, continue to have, the pharmaceutical fund to for pharmaceuticals that are needed by the hospital. But that's, another debate that I'm sure the chairman here, will continue to have that dialogue with you. I had asked the staff to give you a spreadsheet that I'd like for you to look at. And what this is the source, of course, is the audits that on the hospital, and it's on net patient service revenues for the years ended September 30th, 2011, 2010, 2009, and 2008. So it gives you a spreadsheet to see what the differences are. And for patient service revenues, services provided to Medicaid patients, services provided to Medicare patients, MIP patients, services provided to self-pay patients, services provided to other patients, and then a total of all those. Then, of course, what you see in red is less contractual adjustments and provisions for uncollectible accounts. And then, of course, you have then your net patient. So can you please explain now, this is the question I have for you, looking at the spreadsheet. Can you explain why the hospital collections decrease and contractual adjustments and provisions for uncollectible accounts was significantly different in 2011 compared to the previous 3 years?
If you remember the OPA highlight for the 2011 budget, the hospital lost $28 million. And part of that $28 million is we increase our allowance for bad debts. That's why you see an increase in 2011 from 63 to 77. These are all accounting entries. Allowance for bad debt is just an estimate. That means we don't expect to collect 69, no, 70, no, I'm sorry, I don't have a percentage. We don't collect the whole dollar. That's all I can say. Now, if you notice also from this, the 2010, between 2010 and 2011, the total revenue is down by $1 million. This is what I also said, that we noticed that the revenue and the billing is going down. The 2012 is probably less than this too. We don't have it because it's not an audited number yet. Now, what you will see in the books, in the balance sheet, is a net receivable. At this point in May, we are showing our net receivable is $60 million. That is in the book as net receivables, but our gross receivable is $240 million. So 240 minus 60, we're showing like 180 as actually contractual allowance. This is the ongoing contractual allowance. What is showing here is just being booked for the year. This is what is being booked for the year, 2008, 2011. So in 2011, we booked $77 million as contractual allowance. Just a snapshot of the whole year. But what I gave you numbers is as of May 31st, the balance sheet is showing a net receivable of $60 million. However, our gross is actually $240 million. Now, our problem actually now is in the billing and collection area. I have shown my BOT finance that we are short of personnel actually in the business office, and we have plans to do other things than outsourcing billing and collection for a while, because that has not happened. It has been stalled for some reason. I really want to go back to the budget, why we submitted 93. The 93 million is just a compromise. It was 104, brought it down to 84, scared everybody for the $84 million budget, so they said put it back, put back whatever I removed, so that went up to 97, and then I unfunded all the doctors. We are not funding the radiology doctors because we are outsourcing that. We are, right, Mr. Vega?
Did you guys have a conversation before you come here?
Yes, we did. So so that went down to 93. But if you look at the numbers, we are budgeting for 93. We are estimating the 212 will be around 88. So we are on track for that, unless something drastic change. Unless we start paying increments again, then our numbers are off. And I guess we'll handle that when the time comes. But there are opportunities in the big receivables we have. We have to intensify collections so we can collect more.
So since you went back, of course, to this now, and then remember we had asked you the question about personnel, funded vacancies for personnel. And you've indicated, of course, critical areas like nursing and laboratory. services, that you're not cutting, you're refilling those positions. So now in the business office, you're saying that you have some problems there, and one of the problems, of course, is a shortage of personnel. So is there a plan then now to fill some of those vacancies to be able to meet the needs of that particular division to collect? And of course, there'll be a reduction in contractual services where you're outsourcing for somebody to collect for you.
Yes, Senator. During the last board meeting, we got the green light from the Board of Trustees to, in the interim, maybe look at temporary replacement for or temporary hire for the business office. As everyone know, last month or this month, about 3 months ago, we put out an RFP for billing and collection. Unfortunately, we have to resolicit that. We have been there are some aspect of the billing and collection that we have some issues, and we feel that it's in the best interest of the hospital to just resolicit that. So in the meantime, as we know that we're not going to bring this billing and collection team or whatever, we asked the board for a leeway to hire on the non-clinical positions, and I believe we were allowed to look at 3 or 4 positions temporarily to assist us in the billing collection. The fact that they allowed us was because by the end of September 30, there are anticipated 4 retirees from business office. So in consideration, they said we have to plan for those eventual resignation and retirees, so they will allow us to hire on a limited term for business office, billing and collection.
Ray, but I've been talking about this billing and collection, and you're saying that in September you anticipate about 4 individuals retiring from the billing and collection. So the board has said, okay, go ahead and hire temporarily. So you're not helping. You're only going to now fill those people that would be leaving. And we've heard the hospital over a year and a half talk about how billing and collection, outsourcing it, is really the right way to go. The right way to actually collect, what's it about, June, 240 million in AR, in accounts receivable. And it just doesn't seem right that this is not a priority for the hospital you've determined that outsourcing the billing collection is the right way to go to really aggressively collect, because we don't have the capacity. You don't have the capacity to do it. And when you come here and when you guys come and do a request for $93 million, when you know that what you spent, at least in last fiscal year, and what you're going to be spending now is about in the same area, this looks like a budget request if we're the people of Guam to expect a status quo with no improvements. And so that really troubles me. And I've shared this, when I knew that this is the amount that is being requested. It troubles me because we're supposed to look at how to improve. And I think, and I can't speak for all my colleagues here, but it's surprising that we see a critical, very critical agency like the Guam Memorial Hospital reducing their budget when throughout, everyone is trying to see how we can get more and to improve services, and I didn't want to interrupt the speaker, but earlier we said that we had, or you guys had decreased the amounts, throughout the different divisions. Nursing's one of them, and I want to be able to speak to the nursing administrator who's here. But one area that you guys increased was legal expenses. How can a critical agency like, before I proceed, I want to stand corrected though. Is that what you said, June?
Yes.
And so it increased by how much? 200,000. What is the hospital doing to say that we're gonna cut equipment, we're gonna cut contractual services for doctors, for nurses, but we're giving 200,000 more to an attorney? Where's the priorities there? Where are your policymakers? Why aren't they here today, Ray?
I believe the chairman and the vice chair are currently off island. I've extended the invitation to the rest of the board of members during last week's board meeting. Senator, was that a question on the billing and collection, if I understand?
Yes, no, I want you to answer that, but also I still have more here that I just don't understand. And I know you can answer about the billing collection, but what about the insurance companies? We've seen your latest posting. I believe a few months ago, the hospitals owed about 5-point-some million from insurance companies, and today it's about 8 million. What are we doing? I mean, you come here and you say, okay, we're going to increase the requests on the general fund, on what general fund provides the hospital, but then the hospital, what are you doing for yourselves? I mean, we can always come and talk about how we can get new revenue to the hospital, but the hospital is not being aggressive as it should be. Something's wrong here. And so $8 million for the insurance companies that owe us, I mean, what are you doing?
Senator, if I can answer the billing and collection effort of the hospital. I know it's everyone's goal to help the hospital. On the billing and collection, on the issue of putting a temporary hire versus why don't you get them now, if I understand the question right. The management...
That's not my question. It's not
okay.
why do you get them now. I'm saying, why isn't the billing collection contract that is not just 3 months ago, it was since last year that you guys put out a collections RFP and then canceled it, and then I believe it was earlier this year, or was it late last year, you put out one for billing collection, and up to this point have not done anything with it. And only, now we're hearing for the record that, it's being put on hold, and you guys are going to bring in temporary, temporary staff to augment the business office. And it's not augmenting when you know those people are going to be leaving. It's just replacing them.
Senator, the temporary workers is actually my suggestion. I suggested that we break a vacant position into 4, and I make these people community workers who already like an accountant, a medical biller, a data input. I want them to work on Saturday and Sunday to be supervised by a normal staff. I want them to be working from the community, not from the government. Come and work for the hospital. We train them a bit. And the idea is I will have a Saturday, Sunday workforce, even evening, to augment my billing and collection. And we will track that, and hopefully the numbers will show that everything increased. The billing increased, the collection increased. We will track it. And also the idea is, if I'm going to have 4 people leaving the business office by September, hopefully I can expose these people who will apply for the job to see the job in the hospital, and I can entice them to move. It's an idea. It just started from last Thursday's meeting. I have communicated this to Mr. Vega, to the HR. I have identified the positions. It has not gone out. This is the first time it has gone out to the community, even to you. The board blessed it because they said that the billing and collection will take a little bit more time. But I do need the help now. I need hands and eyes in the business office to do the normal work. So this is not going to be permanent as is. When the billing and collection happens, these part-time on-call employees will be gone.
Yeah, and believe me, June, I support you. I support that.
Thank you.
And I've been saying, give you more people. And so that 200,000 that you guys are saying you're going to use for an attorney, get it for permanent people. Don't just use it for these temporary people. I support that effort, June. All I'm saying is, why is the billing and collection being on hold?
The The RFP has, on the billing and collection, we have officially put on notice those prospective bidders that all the offers have been rejected and will be resolicited. There are some aspects of the business and collection processes that were kind of like ambiguous and was not clear from the very beginning. So it was just the panel decided and recommended to just reject all bids and then resolicit.
Yeah, and so that's what I don't understand. And, you know, we can go on and on. We have other providers here, you know, other clinics. I'm sure there are clinics and they're not hospitals that use, you know, these billing and collection companies that do a fine job. You know, I was at one function, and this one service provider touted the fact that they collect 100% of what they bill for. And, you know, and I just don't understand. I don't. And I keep asking. I wrote a letter to the governor as well asking to please get the board, get the hospital to act on this billing and collection. June, you know how important it is. And so I don't understand. I really don't. And so this budget of $93 million that is less than you know than what it is previously, I believe is a disservice. You know, if we are to improve the hospital, then that's not the way to go. And I hear that in the nursing department, we're saying we're not, you know, you're not going to hire, but you're going to fill those that are going to resign and retire. But we've known for talking to the nurses that what is needed is the more experienced nurses. And so when you just fill those positions that leave, you're not going to be getting, you know, the people coming out are going to be entry level. And so, you know, it just doesn't make sense to me. And the most eye-popping to me is the increase in your legal expenses.
Okay, thank you. I'd like to just take you back again, and after I have just a few more questions, and I'll ask the chairman, of course, to continue with his line of questioning. But on this chart that I've given you, were these contractual adjustments that are on the red and provisions for uncollectible accounts then for individual private insurance companies?
Yes, ma'am, including private insurance companies.
Okay, so what I'd like then for you to provide to the committee is that we would like to have a detailed listing by companies, okay, and also if there's any write-offs, we would like to have that. Can you also then, yes, so provide a listing of the write-off by self-pay patients and what insurance, you know, they had and who have received these services?
Yes, we can do that.
Thank you. So I'm going to go ahead now and
Senator, can I just explain that and give you my explanation of the contractual allowance, and I know you want to write up anyway.
yes.
You know, the contractual allowance is really the difference between what the hospital charge and what is the negotiated rates between payers. So when we look at the 3 M's, that we have revenues of 18 million, 32 million, and 16 million, okay? That's what the hospital bills, but we get paid on per diem basis, which is step for rate. So the payments on that, we don't collect $32 million from Medicaid. They're not even budgeted for $32 million. So we can only collect, again, the per diem base. So that's what the contractual allowance includes, basically. So we have, that's the hospital charges versus what the insurance eligible charges. Now, in the OPA report, the difference in really what we collected and the difference in the contractual allowance has to do with many of the patients being shifted to the self-pay. And if we look at the self-pay patients that actually paid this year in 2011, they're much less than they were before. So a lot of people are being shifted to self-pays, and unfortunately they're not necessarily paying. So that's what led to the decrease in the collection of 2011. But that's the contractual allowance explanation.
Thank you very much. So Senator Dueñas, Senator, I'm sorry. Oh wait, before, can I just recognize the other members who have joined us? I'd like to welcome Senator Tony Ada, Senator Chris Dueñas, Senator Sam Mabini, and Senator Frank Blas Jr. So, Senator Rodriguez, any questions?
Yeah, just going back to the what is currently owed by the insurance companies, June. I know it's increased to $8 million today, Is that correct?
What I have been doing, Senator, is because it's important. I've been tracking the numbers every week, and my last number is from week ended June 18 and week ended June 25th, and I did a take care, select care, stay well, and net care just analysis October 31st and prior, and then I did November, by the month, November, December, January, February, March, April, and May. So anyway, my point in this is because we're posting these numbers on the website, I'm posting big numbers, and the project I'm doing now with the business office is to post the payments as fast as we can and to clean up the accounts. And 2 weeks ago, I found out that patient share are still sitting in the insurance account and has not been shifted to the patient share. So actually, that's what the business office has been doing too, along with the other work. So if it's still under the insurance, no collection effort is being done because the insurance is not going to pay for that anymore because they said it's not theirs. And we do not send any notice to the patient because it's not under self-pay. So we're moving that. And now for June 18, the total for the 4 insurance is 7.6, and for June 25th, the total for the 4 insurance is 8.1. But I'm not keying in on the May and June billings. The AR for the 4 insurance in May, it has increased by 2.2 million, and for this month, first 25 days, it's 1.1. This is just billing. It increased the AR because we billed this. But again, I'm keying in on the October 31st and prior numbers. Why would I be showing 492, 600, 1.2, and 100,000 for this insurance? So I'm keying in and cleaning that up. If it's not going to be paid, if it's for a reason it's not ours, I'll have to write them off. If it's patient share, we'll have to bill the patients. But how bad could that be? Because it's last year, we haven't even billed the patients. So even one of the board members said, should we bill the patients if we made a mistake? We'll think about that. It's soul searching why we should be billing patients for services in last year, like in July and August. So,
Can you provide a copy of that to the committee, please?
yes, I have some copies, but if someone can make,
June, are those numbers that you just mentioned, are those the clean numbers now that you have?
as of June 25th, I do this every Monday. I keep track of it, and I have a meeting with the business office people.
So that doesn't include the patient share? That you
It may include the patient
So it's
share
not
on
clean,
this
it's
one.
not clean.
This is just insurance.
Okay.
Patient share is included here.
Is it, okay, so it's not clean then, it's not truly, it doesn't reflect truly what these insurance companies owe?
Correct.
Okay. And so, but you say you're working on that, right? To separate, to determine what is going to truly be billed to the insurance and what is going to be billed to the patients.
Actually, we bill the insurance, and then they will tell us which is patient share. That's how it happens. We don't bill the patient until we have exhausted every avenue with the insurance.
Senator, let me see if I get this right. The numbers here represent the initially what was gross was billed to the insurance identified, and if there are explanation of benefit, coordination of benefits, or payments made partial or in full, then GMH would have to do the transaction entry on that one. And I believe part of this may be part of the patient share, and that's what June was saying. We have not, business office have not completed transacting the rest of this payment. So just like, for example, if there are patients deductible, when we send the bill to take care, it's although there's let's say there's $100 patient deductible, we're still going to send $1,000. So if we do not reconcile that from GMH, then it would still may show, and you understand, it may probably a patient share, but it's still showing under the commercial account.
So you have a certain amount of time frame to bill your the insurance company, right? Which is
Yes,
which is 90
based on the Prompt Payment Act.
which is 90 days.
90 days.
So what about to the patients? If you determine that it's a patient share, there's no, you can bill them after a year.
The Prompt Payment, we have to bill them reasonably, but the Prompt Payment Act has no set limitation when there is a coordination of benefit, just like take care and the self-pay and the patient share.
I see. Okay. Okay, and I just have another question. We've noticed on the breakdown on the anesthesia department, there was also a decrease there in the amount of what is being requested versus the current year.
If that is the total request, that includes salaries. I think I unfunded one of the anesthesiologists, and they get paid like $380,000 a year.
So you've funded it, so that person won't be there?
Yeah, that was funding for one of the anesthesiologists from the Modesto group,
Okay.
and then we're not using them.
Okay, because a few months ago we talked about, this whole this whole epidural thing, came about, and there was talk about how the challenge was, how are we going to fund it, right? Because you would need a dedicated anesthesiologist for that service. It doesn't appear that that the hospital is going to follow through in implementing that service. Am I correct on that? Based on this budget.
Senator, I've been listening to the discussion here, and I'm not a finance person.
Me too, Doc.
But from what I understand, okay, is that historically, when the Guam Memorial Hospital comes before the legislature with a budget request, we basically, there's nothing else appropriated to meet that budget other than what we get in revenue and what we pay out. And there's a fixed allocation to GMH. So from what I understand in the discussion about this, there's no point in showing a budget of $113 million because we're only going to get $90 million. I mean, that's my understanding because there's no other appropriation funding for it. So as we, eliminated some positions here, we're saying that when times comes that we need to fill up those positions, we're going to try to be creative and try to come up with the funding. My understanding is that the positions that have been identified are established positions with funds and appropriated funds, and so it'll be harder to create positions now as we move forward. But from what June tells me, the tradition of presenting a budget is, we present a budget $113 million, but we only get $90 million, so there's no point in putting $112 million. So we take out all those positions that haven't been filled, so we can show a budget of what we actually expend out. But in the moving forward, we're still looking at getting services filled, and really this is not going to impact patient care. If the need for patient care comes up, I'm told that we're going to be creative in how we're going to find money. Now, again, I'm not sure about how budgeting relates to actually, real-time need. I mean, if you're not budgeted for a position in anesthesia, if one comes up, whether I can't get that position versus it's harder, whatever. But, again, that my understanding is that's the rationale for some of the eliminations of the positions and showing a realistic budget of what, we've asked for and what we really end up getting, because we're not going to get an increase in the pharmaceutical fund. We're not going to get an increase in the other funding, and unless we get a subsidy, identified subsidy. So that's why this budget is created at $93 million, from my understanding. June, you can correct me if I'm wrong in that impression, but that's why that's what I thought was the reason for the budget as it is.
Thank you, Doc, and thank you for also saying you're not a finance person, because I'm not either. I'm not a professional. But, you know, the, 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 what I know and what I've seen the past year and a half is that I understand what you said, that you come and say, okay, even if you want 200 million, but if you only collect 80 million, 90 million, that's all you're going to get. But that's thinking that we're going to operate status quo. You have a $240 million accounts receivable, and sure, big part of that we're never going to collect. A big problem with that is the reimbursement rate for Medicare. But if we ain't doing anything to collect a good majority of that, then we're never going to improve. We're never going to move forward. $8 million, in outstanding in just one area. There's 3 areas, right? In the hospital, there's the 3 M's, there's self-pay, and then there's this insurance, the private insurance. That's within our control on how, it's within your control on how you guys can bring in more revenue, so that we don't say, just because we know we're only going to collect 90 million, so we're going to just stay there in 90 million. But when you guys have, you guys have the means to collect more and improve services. And I think that was what I was, that was my question on the epidural service, is that we talked about this service being offered, but can't be offered unless we have the resources. But if we don't talk about it now, if you don't say now to your board, this is something we need, we're going to have to get more aggressive, and in terms of the increased funding from the legislature, it actually is an increase, right? From the 2 sources that you get, it's an increase for this coming fiscal year. And so I'm sure, that's something that we would debate here in the legislature and be willing to provide, because we've always known the importance of providing the assistance, to the hospital. But if you don't come and say we need this instead of this amount, then, if you don't ask, then it's not going to happen.
Just going back to professional physician service, we're really looking at, the services that we open up to be cost neutral, because they would be capturing the professional component. So if we do establish an epidural service, we're hoping, that's a service that I think would be reimbursable, that would support the physician salary. So again, that's where it may not impact the budget now as far as the creation of the position and so forth. I will leave that up to my CFO.
Okay, because the last hearing we had, that that service is not covered by the local, by MIP. I don't know. That's
right.
That's what.
Yeah, right. And I did say that, but I think with the community, calling for it, I think public health will need to take a different position. I think the insurance companies will need to take a different position. But, we need to, I'm still, in fact, in a week I'll be getting somebody to establish that program, at least, implement a plan for going forward. And we're still looking at the the reimbursement issue. But I don't think that will be a major challenge from what I hear with the discussions with the insurance company.
Okay, so I'm just requesting if the hospital can revisit that portion of the budget. I know the speaker had asked to revisit other portions, but specifically, that's my request, is to look, because we've been talking about it. And if we don't have if we're not going to do it, then someone has to say it. But I think since you're right, Doc, there is that call from the community, then that's something that must be considered. Okay, I think that's it.
Just to follow up what you've stated, Doc, is that, and I had asked that question earlier, is that have the hospital been receiving its allotment, and is the decrease or the non-expenditure of the money as a result of no cash? And the answer, of course, that was not the problem. So whatever then in this case that the legislature had appropriated, that means that is genuine, that we want to give, of course, that amount of money based on the needs of the hospital, at least at that time. And if you've expended less, it is definitely not the decision or the actions of this body at all. That comes from the executive branch, who will release the monies to all the different departments and agencies. So if we appropriated $112 million, but then you're tracking and expending only $88 million, then, that's not from the legislature, and I need to make that clear. Because although, we make the appropriations, we don't release the monies, okay? And you're under the executive branch.
We
The
are,
organic
we
act-
are,
the
sir, we
governor
are,
is
Senator.
the head of the hospital, so therefore you need then to go to the front office to get your monies released so you can expend them based on your needs. So, and it's okay, you don't have to answer
Thank
anymore.
you.
I'm just reiterating what you said.
Just feel sorry, Speaker. Okay, just sorry, I have my notes here. On the outstanding payables, as we see it here, there's no plan to take care of that, right?
Because there's no real cost, no real cost, we owe vendors about 9.4 over 90 days. That's a big amount of money. So at any given time, any vendor can put us on hold, especially off-island vendors. Our local vendors are more sympathetic to us. They can carry us longer. But we do make payments. So we had some money that came in, like in December, we got 6.4 from tax garnishment. We got Compact Impact, $4.1 million. And we are getting our money from DOA. Like you say, it's up to us to help ourselves. We have a big receivables. That's why this job landed on my lap 3 months ago, and I see the importance of both. I have vendors calling for payments, and I have a big receivable. So I gotta somehow make sure that the receivables are being collected to pay the vendors.
Senator Yamashita?
Thank you very much, Madam Speaker. Welcome to your legislature. We thank you. Yesterday, Dr. Lozama, Mr. Vega, thank you for the time that you gave me. When I first heard, there was a decrease, 17%, I was like, wow, that's major, because everyone else who's coming wants a lot of money, right? A huge increase. But then as the conversation progressed, and I appreciate, it sounds like you're really trying to be a good team player within the whole government. You're trying to be smart about what you're asking for. But I must agree that the efforts for the collection agency, that whole issue really needs to be a top priority item, so that we can collect the money from the people who go to you and whom you help, right? And so, and I know you already know that, but I just wanted to state that. Sir, you made a statement early on about perhaps the reason for the decrease in the budget request was that there were less patients that were seen, right? Do we have a number? Do we actually know how many less patients were seen?
Yes, I can get that. So
Okay.
I don't have it right now, Senator.
So that for me is a significant data piece, because if it really has gone down, our birth rate remains steady, right? 300 a month. Our census is the same, so I'm kind of curious as to where our people are going to get the help, and so I'd be interested in that data piece. I'm wondering how the skills nursing unit is doing, and are they getting the kind of support that they need? And does this budget support them?
Yes, Senator, based on our estimate, actually, we're probably for the cost of opening up and running the skilled nursing facility-wise, minus the salaries and benefit, it's about an average of about $460,000 a year. Yes, we are trying to address the moving forward of the facilities. We are actually trying to rehab some of the infrastructures there. I believe that building, the facility, has been in existence for about 15, 16 years, and all the infrastructures there are still from day one. we are doing something as far as the replacement of the chiller, main chiller. Yes, we are. We're looking at their power generation. This is about the long overdue that we have to have a plan. We are tapping on grant opportunities, and by the way, that has been the support we're getting as far as the capital improvement project from the hospital, given that our revenues are pretty much goes towards patient care. Any CIP equipment or rehabilitation of the facilities, we're tapping the grant opportunities like DOI and the bond money.
Thank you, because that certainly has become a real valuable place for many of us. You know, after Dr. Lozama treats us, we have to go recuperate there for a little bit, and it really has been a godsend, and I appreciate that. I also want to make a statement about the intensive care unit. It's always full, and so, you know, as we're talking about a decrease in our budget request, I just think, and I'm sure you have a capital improvement plan, I'm sure you have a vision, but I think we really need to look to how do we have more beds available. And I know prevention is always key. We need to be healthier, but right now we're not healthy, and so our community needs a place to go. You know, what we talked about yesterday was our mental health support for our people, and again, I keep looking at this number in front of me, about a 17% decrease. I would ask that as you move forward, that we really incorporate what it is needed money-wise. I know we talked about an MOU that's needed with mental health, but that needs to be incorporated. And if that's going to require some money for us to help pay for psychiatrists or psychology support, we need to do that. So I wanted to be sure I said that statement. And you know, Mr. Vega, I also want to state this. You know, I was at the private hospital groundbreaking, and you were graciously there. You were graciously there, and I appreciated you being there with your head held up high, and that meant a lot to many of us. But I do want to say this, that you need to let us help you. You know, I understand why you came here and how you postured. I do appreciate your cost-cutting measures. You know, I think that's great that you found less amount of contract for your transcription, no travel nurses. HR is making some shifts. I appreciate all that. But let's make sure that we put effort into retaining the people who are helping our bigger community, right? Private versus public. We, you know, be straight up with us and let us know what we can do to help you. And a big part of that is just telling us. But I do, again, agree with Senator Rodriguez that whole RFP needs to be a top priority to get your collection and billing. And you know, I say this to DOE all the time. I'm not sure why they have so many problems with the procurement process. And I'm going to say the same thing to you. You know, it's like we can't keep making mistakes because the time is of essence. And in your area, you know, the health and the emergency of it all is really crucial. Thank you very much, Madam Speaker. Thank you.
Senator, if I can just, yeah, you did mention the renovation of the CCU. Let me just report to the Guam Legislature here very quickly that the ER and the CCU expansion project, which is valued at about 7.56, has been on the A&E design phase right now. I'm happy to say that we already have reached 100% design. We are on track as far as the completion date being still at January 2014. So, and yes, thank you for the Guam Legislature. This is a 7.56 Go bond of 2009 series. And right now what we're trying to address is we have identified a 1.4 million for the medical equipment and the beds, the furnishings and everything, but we're still probably short. We're trying to tap on the grant opportunities. With regards to the overloaded, full capacity CCU, just to let you know, Senators, that the new CCU would have probably no less than 12 CCU beds with 1 or 2 negative pressure. The footprint of the CCU and the emergency room would be expanded to about 3 times as much. So we are hoping that we would have those in due time, January 2014. So the footprint for both CCU and ER would be increased by 3 times the space. Thank you.
Senator Tyron?
Thank you, Madam Speaker. Good morning, everyone. Thank you so much for joining us. You know, I do want to express before I begin that I do appreciate everything that the hospital does. The medical staff and the nurses are always professional. They always manage to provide the best care possible with a smile on their face despite the setbacks and limitations. So I do want to commend GMH for always doing their very best to provide quality care. And, you know, I also appreciate your ability to look at areas where you can cut back 17% in your budget and your expenditures. But I just want to ensure that while we're making these cuts, it makes sense and that patient care is not jeopardized in any way. Recently, I spent quite a few hours at the hospital with a friend who was admitted, and he didn't have a shower curtain. And when asked, the nurses said, "We don't have any money," so he was reluctant to take a shower. And so, you know, though I know you said that nobody's denied supplies when they request it, but are those areas some of the supplies that we're cutting back?
Definitely not, Senators. This is my first time. You know, there's a lot of processes, especially on the direct patient care areas. I've been receiving like complaints about there's no bath towel. There's my first time to have a shower curtain missing.
This was on the 3rd floor
Yeah.
in isolation, so.
Right. You know, I will look into that, Senator. But when you know things like there's no bath towels, you know, when I ask the staff, it's just a matter of we have those. Some of those supplies we have. It's just a matter, I think, you know, the perception that you know there's not truly a coordination between the laundry department, the nursing services, and the rest of the staff as far as this one.
Okay, and then just going back to the hiring of nurses, maybe if I could suggest, maybe you could just kind of revisit that and maybe reconsider your decision and allow for additional hiring, because I know that the nurses there are overworked, and while they are allowed to make overtime, and that's good for the pocketbook, sometimes they're just very tired, and they'll do it just because they know that there's no one else to fill that void if they go home. So, I mean, if we could just hire additional nurses, if that's possible, I think that would be important.
Senator, with regards to the nursing, there's no hold on the nursing. The challenge we have, and I think the assistant, the nursing director is here to confirm that, is that borrowing her words, we're bottom heavy on entry-level nurses. We have a lot, even for one position, there's like 20, 15 applicants, but those are staff nurse, entry-level nurse. What we're actually looking at is critical skilled nurses, like in the emergency room, L&D, and CCU. So those are, I believe, some of those that are currently being recruited are non-entry level nurse, but skilled nurse in those specialty areas.
Okay, thank you so much. Thank you, Madam.
Senator Soniana?
Thank you, Madam Chair. Ms. Vega, are we still with the insurance companies? Are they pretty much up to date on their payments?
No, they're not. I can say that because I've been pushing.
What is the longest aged?
If you have a copy of that, you can see how old. To my eyes, they are really old, and I'm trying to clean it up as fast as I can. And I'm pushing for this one because I know there's real money on this one.
Now, are we still giving a discount to these insurance companies when they pay?
Yes, we are.
Why don't we charge them an interest when they don't pay?
the problem again is they are normally driving this, and I got no people to actually to say, no, you should not take this discount, we will charge you interest on this. And we've talked about this many times, that we are just sometimes accepting what they say.
Yeah, but I think sometimes that's the problem. We just accept what they say. You know, an insurance company, if I don't pay my insurance premium, they cancel my insurance coverage.
And that's, I understand, Senator, and I'm trying to change that. I'm trying to. I've been telling my personnel, I don't understand why every 2 weeks we kind of beg for payment to fund our payroll. I said, I don't think we should. I'm seeing these big numbers. Why should I be begging? You know, we should be actually driving this, and it's not easy to change that. We're going to have a series of meetings. I've been trying to set it up. It's not going to be easy, but I'll do my best.
The patients that are self-pay, when they don't pay within a certain time, do we charge them interest?
No, we don't charge interest.
We don't charge interest.
No, sir.
But when they don't pay, and they do have a tax return coming to them, we garnish their tax return, don't
We garnish their tax return.
So then, how come we can't strengthen the collections against the insurance companies?
It's again, I will put the blame on the hospital on this one. I guess I'm to blame because I'm in charge. But I'm trying to change that. I'm trying to put more teeth. I've been sending emails. I've been asking for meetings. So this
What
will
is it going to
change.
take? Would it take the Board of Trustees or the administration to set up meetings with these companies so that everyone can come to the table and work out some type of arrangement to where they'll be able to make frequent payments to what's going on?
Senator, with regards to the meeting with the insurance, there is an ongoing monthly meeting actually. It's just that the reconciling of this account, including what's portion they'll be responsible and what other or secondary payer or the patient's share, that has always been the discussion. And I said earlier, you know, it's if the on this paper June is stating that one company owes 2.1, that's not exactly what the responsibility of that insurance. It's probably there's coordination of benefit and the deductibles. So June is taking this by heart as far as the trying to work on the accounts receivable. And you know, in fairness to the company that we've been meeting every month, yes, we are engaged every month with the insurance company.
So we're taking a harder approach at collections then?
Yes, sir. Including the implementation of the Prompt Payment Act, wherein it allows us to charge a 12% per annum compounded when they don't pay us within 45 days from the time we bill.
I see. Okay, thank you. Thank you, Madam Chair.
Can I just add, do you have reference to the AR from June? I mean, if you look at that AR, you know, I just want to point out some numbers here. If we look at, you know, the outstandings from November, there are some that are small. I mean, some insurance companies have small ARs as of 6/25/2012. You know, the ARs that are big are basically from April, right? Which is within the 90 days or 60 days of prompt payment. There are some that unfortunately show a prior year obligation. That's a little bit skewed by some settlements that we did. So what we really need to capture more and give more attention to would be the high amounts that are due before April, right, June? Yes. And because in the smaller amounts, those could be, you know, small items that may be disputable. I need to point out that that some insurance companies have really put the hospital at greater risk with offering plans that put a cap on the hospitalization stay. I think you're aware of that. I mean, $250 for hospitalization a day does not go a long way. So and sometimes that basically leaves a lot of AR into that account. The benefits, there's a lot of exclusion on the benefits. So many of these have to do with, our AR people really reconciling the what is insurance responsibility and patient responsibility. But if we look at the numbers from November to June 2012, I mean, we really are not bad in what is left over for the prior months, except for the April to June. And we are certainly bad from prior year obligations, but those are the challenges that we had before. So June is really doing a good job, and I'm included in that meeting in trying to capture as much revenue as we can with the insurance company for current services. Thank you.
Thank you, Doctor.
Senator Dueñas?
Good morning, gentlemen. Ray, notwithstanding this morning, I see a relief in your demeanor. I've been reading in the media that help is on the way. Your relief. June, no relief for you. Gentlemen, I just noticed one thing in the opening and the presentation. It looks as though your attrition is working in terms of non-critical area, and that's where you're levelizing. Would that be correct?
Yes, Senator. We're trying our very best that, some of those positions, so we keep evaluating on a day-to-day basis whether we need those warm bodies or not.
Right. So I'm just happy to see that you clarified, though, that your non-critical is not affected. Also, your retirement now is current. That's correct, right?
Thank you for that bond money, I think, with working with us. Where it's a relief, actually. If you give me a few.
Yes, please.
It's a relief for GMHs,
Right.
because those that have wants to retire, especially on the old plan, sometimes we owe retirement fund like 50,000, 60,000. For us to allow them to retire, we actually make them whole. So with that obligation, prior year's obligation taken care of by the bond, we don't have to set aside money now for future retirees. Thank you.
Right, and June and Ray, really, and I think this is one of the critical things when we're talking about these austere times and a lot of our measures that we're using moving forward to control costs. You also have, this is your highest payroll, no? Because these people have been employed for a long, long time, and especially in the old plan. So when you move in that direction and those retire, it's your greatest yield in terms of entry level pulling in and also savings with regard to that.
That's true.
So we want to maximize on that. So, what we'll be looking at, and I think this is what's key in terms of a lot of the discussion here, gentlemen, this morning, is on your collection ratio, and I trust, June, you're going to be aggressive on this. I can see your commitment. Is that's where you can build in your flexibility in terms of your allotment schedule. Because when you're aggressive on that collection and with your very reasonable budget that you've put forward, then you can make your adjustments in terms of if your allotments are tardy. At least if your collection is aggressive, you have that offset. So I congratulate you guys on all of your efforts. Doc stepped out, so I'm going to ask him a question when he gets back. So thank you, Madam Chair.
Senator Mabini?
Thank you. Thank you, Ray and June, again, for being here today. Now, not to beat us up here regarding the receivables, but as accountants, we know that there's costs associated with having that heavy of a receivable still sitting in the books. I know that in front of us we have the sheet that talks about the insurance companies and their, the aged dates, the aged dollar amounts. The balance of from the 240 million, what is the percentage of age, the age receivables as far as 1 or 2 or 3 years out for the balance? Because we know what the insurance side of the house is. What would you say?
Senator, our billing is, I'll say, averaging from 11 to 12 million a month. That's what we bill a month. So you can say that 30, 60, 90, that's how it's going to go. At least 11 to 12 million is added to our receivables every month. And we've been collecting from 6.5 to 7 million a month. So as fast as we can clean that up, the difference between what we bill and what we collect is probably staying in the receivables. That's why I have a challenge in either collecting the receivable or writing off the contractuals. Those are the challenges we have right now. But I can say that out of the 240, I will estimate that probably 150 of that is over 180 days.
Now, does the agency have just a general projected percentage of what may not be collected?
It's just an estimate.
It's just an estimate.
Yes.
And then last but not least, I appreciate the innovative ideas that you have in approaching the collection process. Has the agency ever considered investing in factoring companies where some companies do this, where they actually sell their receivables, and usually it's it's about a 5% cost associated for buying those receivables, called factoring. Is that something that the agency would consider? Because if that's the case, that would be about $12 million cost out of the 240, collecting maybe potentially about $180 million if you guys did if you did hire a factoring company. Is that something you've considered?
We have talked about that, but I really don't know how to get to that. Maybe we can do an RFI. But remember, though, that the OPA report that our own collection effort is just we collect like 20 cents to the dollar on the average from that last one.
Right.
Remember that, Senator Rodriguez?
Right, and factoring companies can usually collect up to 70 cents to the dollar. So it's just something that you may want to consider. And if I'm not mistaken, banks are the ones who could help connect you to factoring bond companies or whatnot. Because if you consider that dollar amount could be brought in, and as opposed to continuing to expend the receivable portion, it's just something to consider.
Thank you, Senator.
Senator Frank Blas. Junior.
Thank you, Madam Speaker Judy Wampat. Good morning, gentlemen. June, you had mentioned earlier that there was about $4.1 million in compact impact costs that have been...
Oh, we got that for this year, Senator.
Oh, you got that?
We got it, and we used it to pay vendors.
How much have you spent, or what is your... how much have you spent in as far as providing services?
Mr. Vega.
Senator, can you repeat the question?
How much have you spent to be able to provide services to citizens of the freely associated states?
The Senator, the average gross billing for freely associated states, and that would include Republic of Palau and Marshall Island, we're pegging it at about 19 million a year.
A year?
Yes.
Okay. Since you've been tracking it, how much is that cost total come up to be?
Senator, if I can answer that question with a little bit introduction.
Sure.
As I noticed, the past 3 years, we average about 19 million for the freely associated states. What is clear to me is that 78% of those are already in our system. When I say in our system, part of them are Medicare, Medicaid, MIP, and a good portion, of about 5%, are having commercial insurance. I'm tracking them based on their finance. So the true self-pay, as they are registered through the emergency room, roughly translate about 12%. So what I'm saying is almost 70% of these freely associated states are availing of the government assistance program already. And the fact that Medicaid and MIP mirrors Medicare reimbursement rate, this is where the contractual adjustment is. Even if that 19 million, and they're contractually adjusted because they're Medicaid, MIP, the cost, the revenue generated is probably about 6 million only. Did I answer your question, sir?
Yeah, yes. And so what steps have you taken to be able to recoup these costs?
Yes, Senator. The bigger approach is what Dr. Lizama has been working with the federal agencies. We're asking for a relief on the TEFRA reimbursement rate. Luckily, we have their attention at this time.
Have you asked them, have you brought the discussion of regards to the unreimbursed amounts relating to the Compacts of Free Association into the discussions of TEFRA, or?
No, the expenditures that go for the compact impact is not factored into the request for TEFRA, rebasing. As Mr. Vega said, these people are already in the system in the form of Medicaid MIP, so we need to break that apart to really factor in what are the true costs of the compact impact. What we are capturing are the FAS under self-pay, those that are not eligible for the local programs, and those that are under Medicaid, and those that are not available by residency status.
If I can make a suggestion, there's already a mechanism that exists by law to be able to allow for the offset of compact impact costs, for other programs. My suggestion is that in your discussions about TEFRA, you include the Department of the Interior in these discussions with whoever you're talking to TEFRA about, and if there is an arrangement that can be made to be able to get you the relief you need in as far as the lifting of those restrictions based on the offset of those amounts, that could be an argument, a good argument for you. Okay, then you look at a population and a portion of the relief that you're seeking, at least for this. Then we can work on the others.
The TIFRA relief is basically addressing the Medicare.
Understood.
I'm sorry, but the Medicare now. Certainly, public health, is taking some lead into addressing the impact from the compact.
Understood. And I think public health can use the same argument here. This is not going to cost anybody anything. It's recognizing this as an offset. We can offset the amounts they owe us by lifting those restrictions and lifting those caps so that you can include those costs there. So I think that's something that you should look into in that area.
Well, one of the going forward considerations under Medicaid is, amending the state plan.
Right.
Which is to allow for some of our actual cost expenses to be offset, the CPOE or Certified Public Expenditures, CPE. And certainly we have had a discussion with Medicaid and MIP regarding amending our state plan and then petitioning for the certified public expenditures portion to be part of our match under Medicaid, local match. So my understanding in this program, instead of actually the government of Guam putting in the matching requirement in whole, our true expenses at GMH becomes our match, and such the federal government can put in their share.
Okay. And now with regards to so that's something that I think you should look into.
Thank you, Senator.
and actually save us millions of dollars. Now I'm looking at your accounts receivable and the amounts that you still have here in June. And I know that you right now are asking for ways to be able to, my understanding is to bring people on board so they can help you reduce a lot of this. Have you ever thought of being able to look at this and have a discussion with the different healthcare companies and, am I correct here in saying that as of June 25th, your AR here is about $8.1 million?
Correct, Senator.
Okay, so a way that you can probably work an arrangement with, with regards to, I have to agree with Senator Ada here in the concern that, we provide a discount, but then we don't charge interest on the other end, and you've got to agree that sometimes these, if they know that you don't have the abilities to be able to handle this, they'll try to drag it out as long as can because you're not charging them interest.
That's
on this,
correct,
right?
Senator.
But at the same token, if there's a way that you can be, of the $8.1 million, if you can take the $0.1 million, $100,000, and somehow convert that into a position, use that money there to be able to create a position that can directly deal with these individuals. Instead of trying to find the monies within the coffers here, is looking at what is being owed here, and using that to be able to pay for the cost of the individual you're going to need to be able to continue to have the discussions with these companies on being able to pay these bills out. Bills on time.
Correct, Senator. I think the insurance part is easy. This is only $8 million. The part-timers I'm planning to bring in will handle the bigger amounts, the whole total receivables.
Yes, but now while you're trying to do that, there's still $8 million that we have.
Correct.
Okay? And if you use a $100,000 investment to recoup $8 million, I think that's a real worthwhile investment.
It's worthwhile, Senator.
Okay? And the $100 million is right there. See what I'm saying?
Yes.
Okay?
Yes.
It's somehow have the conversations to be with the insurance companies. I'm sure they don't want to have this looming over their heads too as well.
No, they don't.
Yeah. So if you give them the opportunity to sit down and be able to see how you can use some of that money to be able to hire the personnel necessary to help them clear up, what they owe, it'd be beneficial for everybody. It's win-win for everybody.
Yes, sir.
Okay?
Yes, sir.
Thank you.
Thank you.
Senator Duenas, Dr. Lizama's back.
Hey, Doug. No worries. You're a busy guy. When you walk out, that's important. It could save a life. Hey, Doc. I just wanted to, in all the discussions of the budget and the finance, and of course, as your primary role to ensure patient care and the like, are you satisfied walking the halls with the staffing levels and the patient care delivery?
That's a loaded question. Yeah, certainly, we have our challenges in really meeting our vendor payables so that, we can, provide, the tools and equipment and supplies that, the staff and the healthcare delivers at the hospital, meet the standard of care that we want. So, as pointed out earlier by June, we have $9 million in vendor payables that are 90 days, over 90 days, and we have $22 million that has been, stuck in the vendor payables. Again, being the non-finance guy that I am, I don't know where to put that in our budget.
Sure.
So that we can address that as a need to pay. And it's certainly not there. But that affects our daily operations at GMH.
Right.
I know that we've been working with the executive office in trying to meet vendor payables so that patient care is not affected, and I must state that they have been very helpful I understand the economy of the island. I understand the need to cut costs. I'm not going to be here to ask for subsidy if we're not doing our job in-house.
Right.
And I've been working with June can attest that I've been involved with. I'd like not to be involved, but I've been involved with the business office and the finance aspect of the hospital, so that we can responsibly, state our costs, that, it is really due to unfunded liability or mandates and not because of our inability to collect. And so, we're, unfortunately, there's been some transitions here and there. I know the billing and collection has been identified as a opportunity to make some change. I think we need to look at, from my standpoint, there are, Senator, yes, I do respect that there are billing and collection agencies here in Guam that do 90 to 100% collection. My wife was one of them for my clinic. But unfortunately, hospital billing is very complicated. And, I'm appreciating that.
Yeah.
You have to take them apart, a patient gets seen in the emergency room by the emergency room doctor, orders an EKG. That ER doctor cannot bill for that EKG. Has to be another ER, and you have to generate another separate sheet. So those are being challenged by the insurance companies, as we submit those claims. So it is not a simple, process, unfortunately, and that's been the difficulty of the history of the billing and collection. But I think we're moving forward, and certainly part of the solution would include outsourcing some of the billing and collection, whether, that's the whole billing and collection service of the hospital versus, some departments as we outsource a department, maybe the billing and collection can be included in that outsource service. So, again, we're looking and what we can do to take care of our house, to be financially responsible, because, I would hate to sacrifice, education needs for, something that we can, take care in-house.
Yeah, Doctor, and one final question after this. I think that's the important thing for the public to know, is that the hospital, staffing-wise and everything else, stand ready to provide the services. The critical area of the finance really is on your vendor payments and the like, because that's what really affects your ability to provide 100% top-notch care, is that ability to procure all the items you need to do what you need to do and have the professional personnel. And that really is what cuts to the chase. Other than that, it seems like the hospital is fit and ready. So the final question I have, Doc, is on the demand side. Do you think that the downturn is a result of elective and other off-island care that's currently being sought by our people?
We've had some challenges this year with regards to services. The heart project hasn't taken off this year because of some hospital wall hardening projects. So, certainly some services are not currently being provided, and I think that may account for more of the issue on the revenue decrease than the patient census. Moving forward, I was just sharing with, one of the staff that, it's exciting times for GMH. We actually have now an ability to do cardiology service every day. We have a cardiologist on island with the ability to do, cardiac procedures. Unfortunately, again, with our issues with, reimbursement, I just read in the news today about one of our guys being in the Philippines and needing a defibrillator placement. Again, those are things that we will be able to take care of maybe 365 days a year. Again, if we have the means to support the service, and this is where our challenge with the reimbursement under the TEFRA really hits us hard, right. and it doesn't seem to get, to sink in with that, the people that look at the data of our Medicare cost reporting, and we're really looking at alternatives to bring this clinical patient care issues being affected. There's significant disparity here, and so there are some services that we haven't done this year because of some renovations and improvements in the hospital, but going forward, they were still handicapped by the ability to support any service that we introduce.
Yeah. And Doc, I say this also because this actually might be a bright spot, though, because this may be a snapshot of how the new hospital is going to coexist with GMH currently. Because if those electives are, by virtue of that, it looks like we can at least maintain and continue as long as there's not that divide. And so I think we can use this as a template going forward to get an idea of the ratios and what type of services are being provided and how the long-term effect of the two hospitals is going to play out. So I think that's already a start for our committee when they come together to continue to evaluate for the eventuality. So thanks, gentlemen, for your presentation.
Thank you. I just have a few questions because earlier you had indicated that you're not then filling any of your funded vacant positions. And looking at the administrative side, of course, and we all know is that you're now going to hire a new administrator, and it's to the tune of over $200,000. What's the exact amount?
I believe, Senator, it's about 200,000 per annum.
And and then looking, of course, at your request, and you only have one funded vacant position that you submitted for $75,000. Your other vacant positions, there's no funding source. So, how are you going to make up for this amount from the?
The budget was prepared much earlier than when the contract was drawn. We'll have to modify the budget when the time comes, which is July. So we will have to even this budget that we're presenting is for 2013, effective October. But Mr. Verga is supposed to come in 1st of July. So we will have to find money this year already. We will have to modify our budget, get funding from other departments that are lapsing, and add it onto the admin
Either that or
budget.
else you might want to consider Senator Rodriguez's question earlier about the 200 some that you're going to use the increase for legal services. You might have to shift that.
If you're looking at the admin budget, Senator, because we prepared it earlier, if you look at the building insurance, we budgeted that for 700,000. We put that on RFP. It's now down to 482. The actual expense we will incur is 482 for this year and for next year. I think it's a three-year contract for the building insurance. So we have some savings on that one that we can offset the other ones.
Well, that's provided, of course, that the language in the Budget Act is going to allow you to be able to shift monies, between object categories, because personnel is different. Normally, the rule is that you never shift monies from the other object categories to support personnel, and that's what I'm saying. So, and that's important to know exactly what it is that you're going to need. In terms of amendments in this Budget Act that would allow for any monies to be shifted between object categories.
Senator, the BBMR does not see our records. We keep our own records. We are on enterprise accounting. We are not on municipal accounting. BBMR does not do allotment and give us our monthly allotments. We control that ourselves.
Yes, but still, the authorization to do what you need to do,
Yes,
of
we
course,
do.
need to be done and authorized by law.
Yes, and we actually submit that to the board. We modify our
I think
budget.
you should also make sure you have that discussion with the OFB.
Thank you.
You had said earlier, of course, based on the bonds that now you're able to pay off their retirement debt. What was that dollar amount, the total dollar amount?
We are out of that 25 million as for DOE and GMH. I think we get 18 out of that.
Okay, and you're all caught up. And how many now, as a result of the fact that you're caught up with the retirement, how many people are actually retiring now from the hospital this year?
actually just brought the DB employees up to date, like me. I'm not planning to retire yet. We're going to take inventory. As far as I know, there's 4 in the business office, but we are not encouraging them to retire. But if it happens, they'll be able to. We will take inventory. We will ask
Okay.
them.
So can we get those numbers as well,
Yes, ma'am.
as to how many will be retiring then? Okay, if, since there aren't any other questions, I'd like to say that it's now 10 minutes after 11, and we have, of course, conducted the public hearing, the budget hearing for Guam Memorial Hospital, and we will continue, of course, to keep, the lines of communication, open to continue to have you work with OFB. And we'd like to thank you very much for coming in this morning, my colleagues as well. And Mr. Vega, if you'd like to do any closing remarks, this is the time.
Thank you, Senator. It's been a wonderful 16 months, I guess. First time to meet the legislature in this formal setting. I was asking myself, what am I doing here? But I have to express my appreciation and thank you to Guam Legislature, the senators, for making the path so easy. You provided me some comfort and you made me at ease most of the time. Yes. I just want to publicly acknowledge that. Thank you. And thank you for helping Guam Memorial Hospital. I'm proud of the management and staff of Guam Memorial Hospital. Thank you.
If I can add, Madam Speaker.
Senator Rodriguez?
Thank you, Madam Speaker. Ray, that sounded like a farewell speech, but I know it's not, because and you know that we've always supported you and your team there. We've had challenges that we try to face it together, but I got to say, Ray, that you've done your best there, and I know and I'm hopeful that I will still be able to see you there at the hospital, because we bring someone in, he's not going to know things right away. And you know my position on that. The people know my position on that. I don't have to say it here again. But you guys have done the best that you could. Unfortunately, we don't have, your policymakers here to defend, the actions that are being taken. A lot of times you guys are acting on the decisions that they make. And so it's just unfortunate that they're not here today with us, especially in this very critical aspect in the budget. So thank you.
I plan to stay, Senator, but not the center of attraction anymore.
Well, earlier I did announce that you did budget for the assistants. I'm wondering if that's the position you're going to be stepping into. Anyway, Senator Blas, did you have a
Thank you, Madam Chair. Ray, I have to express the same sentiment as Senator Rodriguez. Where do you think you're going? Okay? And I say that with all due respect. You were thrust into this position, and being thrust into the position, you took the bull by the horn. And Mr. Vega, one of the things that I admire about your leadership is that while you were trying to learn and you were trying to provide the best to the people of Guam in as far as the hospital, you were a true leader in being able to take responsibility for many of the issues and many of the concerns. That's a sign of a good leader. You can delegate the authority, but you can't delegate the responsibility, and you always were responsible for all the actions. And you took it, and you went after taking it. You went back and you made it better. And that's one of your great assets, and I want to congratulate. Thank you for that. Thank you for your service there. But no, I think that you provide a leadership style and a leadership that could be used, continue to be used in building our hospital, building our health industry, and building our island. Thank you.
Senator, just for the record, I didn't do it myself. I have Dr. Lizama here and June Infante.
I just, sorry, I'd like to also recognize Senator Munya Barnes, who's also here. But we completely forgot to ask you this question, that because, there's all this discussion in terms of, you making some cuts, and now can we safely then let everyone know that there is the threat of the 32-hour, hours would no longer then be an issue, or is not an issue anymore?
That 32-hour work week